Welcome to the AANN webinar, Putting Guidelines into Practice, Care of the Patient Undergoing ICP Monitoring, External Ventricular Drainage, or Lumbar Drainage. Next slide, please. Our presenters today are myself, who will serve as the moderator primarily. My name is Patricia, or Pat Blissitt, and the two speakers who will present the bulk of the presentation will include case studies are Tess Slazinski, who's a clinical nurse specialist in the neuro ICU at Cedars-Sinai Medical Center in Los Angeles, and Paula Zakzewski, who is the pediatric neurosurgery nurse practitioner at University of Chicago, Comer Children's Hospital, Chicago, Illinois. Next slide, please. The objectives for this webinar are that the participants will be able to review the development process used for the AANN ICP EVD lumbar drain guideline. They'll be able to navigate the guideline to find desired information to improve clinical outcomes. They'll be able to discuss nursing management of the patient requiring ICP monitoring, external ventricular drainage, or lumbar drainage. And finally, they will be able to describe setup, insertion, troubleshooting, and complications of ICP monitors and CSF drains. Next slide, please. For an overview of the CPG development process, we'll have a little discussion about that. So the idea is that we have synthesized the available literature on a specific topic in order to provide nurses with the foundation they need to develop and implement their own practice guidelines, performance measures, educational programs, and other strategies to improve the quality of health care in their own organizations. They are systematically developed by experts and peer-reviewed. Next slide, please. So, in brief, the algorithm or the process for the clinical guideline development is as follows. There's a guideline panel of experts identified. Next, the expert panel identifies and reviews relevant evidence and formulates recommendations for practice. Then the guideline undergoes a blind review, followed by revision of guidelines based on peer review comments, and then finally publication of the clinical practice guideline. Next slide, please. So within the guidelines, the evidence is leveled based on the available publications that can support that level of evidence. So level 1 recommendations are supported by class 1 evidence, and those would include publications that represent randomized controlled trial without significant limitations or a meta-analysis. Level 2 recommendations are supported by class 2 evidence, such as a randomized controlled trial with important limitations, or an observational study. And then level 3 recommendations are supported by class 3 or class 4 evidence, such as qualitative studies, case series, expert opinion of the guideline panel, standards of care, or clinical protocols. Next slide, please. So for our CPG overview today, to give you an idea of how to follow up with additional learning, they are available. Each CPG that we have published is available via the internet at www.aann.org and may be downloaded. And for today's webinar, no contact hours are available for today's presentation. However, contact hours may be obtained by reading the clinical practice guideline and completing the post-test. CE credits are free to AANN members. Next slide, please. So the format for the remainder of the webcast will be as follows. There will be an adult case study with application of the guideline presented by Tess Slazinski, and then the pediatric case study will follow by Paula Zakzewski, and then all of us will participate in some questions and answers that have come to us previously when the webcast was originally recorded live, and these will be primarily around areas of controversy. Next slide, please. So without further ado, I will hand this over to Tess, who will present the adult case study.
Hi, this is Tess Slazinski. Next slide, please. The case study is of a 43-year-old female that was admitted to the emergency department with headache, status post-seizure, and altered mental status. She had no past medical history. Her admission GCS was 12. The emergent head CT revealed subarachnoid hemorrhage involving the basal cisterns. Neurosurgery consultation was obtained, and an urgent CTA revealed a left supraclinoid ICA aneurysm. The patient was admitted to the neuro ICU for close monitoring. Next slide, please. The patient had further neurological deterioration, and an emergent bedside EVD was placed. The patient began following commands 1 hour after EVD placement. The patient was then taken to interventional radiology the following morning for a coiling procedure. Next slide, please. Just a little short intermission from the case study for some teaching points. An aneurysm is an abnormal localized dilatation of the cerebral arterial wall. Next slide, please. That is due to a weakness in the wall. And we can see a great operative picture here of the parent vessel and the aneurysm coming off of that. The aneurysm will then can rupture at its weakest point, called the nidus. Next slide, please. The incidence is about 30,000 individuals in the United States per year. It's about 6 to 7% of all strokes. The average age is about 50 to 60 years of age, greater in females than in males, and 25% roughly of patients that have one aneurysm have more than one aneurysm. Next slide. 10 to 15% of these patients die before reaching the hospital. 30 to 60% die with the initial hemorrhage or secondary sequelae. At 30 days, there's a 50% mortality, and then at day 90, there's a 55% of the patient population have a good clinical outcome. The best outcome for patients is ones that are admitted to major medical centers with the capability to perform interventional radiology procedures within 7 hours of hemorrhage. The causes of death are the initial hemorrhage. There's a 50% mortality. The rebleeding is within 24 hours for aneurysms that are not secured. And then the mortality jumps from 50 to 80%. And then the vasospasm window is 3 to 21 days. Next slide. When an aneurysm ruptures, patients can bleed into the subarachnoid space. There can be an intracerebral clot or intraparenchymal clot, and that's about 50% of MCA aneurysms or intraventricular hemorrhage. Next slide. Subarachnoid hemorrhage, the subarachnoid spaces hold about 150 cc's, and we can see in this schematic that the subarachnoid spaces are going to become filled, and then the blood is going to follow the pathway of least resistance, and in this case, into what the picture shows here, the anterior horns of the lateral ventricles. Next slide. There are several indications for EVD placement. In this case, it's temporary drainage resulting from acute hydrocephalus from subarachnoid hemorrhage, and then subarachnoid hemorrhage with a Hunt and Hess scale of greater than or equal to 3. Next slide, please. Prior to insertion, we want to make sure there's an informed consent. Ventricular catheter insertion can cause cerebral hemorrhage. It can track hemorrhage, and a INR of 1.2 to 1.6 is acceptable in adults. Ventricular catheters are placed in the operating room, in the emergency department, in the radiology department, and in the intensive care unit. Next slide. The disadvantages of an external ventricular drain is there can be difficulty hitting the ventricles. The ventricular catheter can become occluded with blood. And there's 3 concepts that we always want to think about with drains, and that is 0 to atmosphere, 0 reference, and pressure level. The external transducer has to be re-zeroed at least once a shift, and when other troubleshooting methods are ineffective. And we recommended in the guidelines that the 0 reference is what needs to be, so in other words, patients need to be re-leveled instead of re-zeroed. Next slide. Priming the EVD tubing, the tubing should be primed with preservative-free normal saline, and the use of infusion bags or pressure bags to prime the system is not recommended. It's also recommended that a flushless transducer should be attached to the system. So transducers that are traditionally used for arterial lines or central lines are not to be used in this device. Next slide. And just an example, this is a panel mount system. There are several different types of systems. This is showing the stopcock where we would 0 to atmosphere. So traditional zeroing off to the patient and open to air is what the guidelines recommend. Next slide, please. This is a 0 reference level, so the 0 corresponds to the transducer, which would correspond to the external anatomical landmark. That can be the tragus, it can be the outer canthus of the eye, it can be the external auditory meatus. It doesn't matter as long as one facility picks one landmark, so that every nurse, every day, every shift is using the same landmark. So for example, our facility uses the tragus. Next slide, please. And this is the pressure level. So the cerebral spinal fluid has to reach this pressure within the head before it spills over into the graduated burette. Next slide. The Panamount stopcock is open in this patient from the transducer and closed to drainage. So in this case, we would obtain a pressure tracing and obtain a number and calculate the cerebral perfusion pressure. Next slide, please. In this case, the stopcock is close to the transducer, and the drain is open from the patient into the graduated burette so that we can drain cerebral spinal fluid. Next slide. The frequency of assessment really depends on the setting. In the intensive care unit, it's usually Q1 hour. ICP and CSF output color and clarity are documented every hour. And then just general visual observation of an EVD from the patient to the graduated burette is on a Q4 hour basis. And it's just so that we're just hypervigilant about the device. Next slide. These devices either drain CSF or monitor ICP. They are not capable of doing both. Intermittent drainage is going to be the process of monitoring ICP continuously, and when the ICP is greater than a prescribed number, the drain would be opened. The amount would be a prescribed number that's drained, for instance, 5 cc's of CSF, and then returned to monitor ICP. Continuous drainage is when CSF is continuously draining, so open from the patient to the graduated burette. And then ICP is usually checked at a prescribed interval, so for example, Q1 hour. Next slide. And we'll just return to the case study. Due to the extensive nature of the patient's subarachnoid hemorrhage, she required constant CSF drainage vigilance. The catheter became clotted several times, and that required flushing away from the patient. This is only performed by advanced practice nurses or physicians at our facility, and I recommend that each facility has their own guidelines for this. The bedside nurses were able to quickly identify when the drain was not functioning properly. Next slide. The patient on post-bleed day 6 went from following commands and moderate vasospasm to not following commands and critical vasospasm that was detected on her transcranial Doppler. Interventional radiology confirmed cerebral vasospasm and a balloon angioplasty was performed. She also had brain tissue oxygen monitoring catheter that was placed to assess further information of vasospasm. Next slide. Just some parting summary words. The EVD requires vigilant maintenance. Careful orientation to these devices is essential, and annual skills-based competencies are suggested. For our traveler staff and career float staff, we don't have them take care of these patients unless they've demonstrated a skills competency. Thank you very much.
Next slide, please. So our next case study will be a pediatric case study, and that will be presented by Paula Zakzewski. Paula, next slide, please.
Okay, our pediatric case study for today is patient MY, who is a 19-month-old female. She's an X23-week preemie with hydrocephalus secondary to a grade 4 intraventricular hemorrhage. She had a ventriculoperitoneal shunt placed shortly after birth. And then on this admission, she presents to the emergency department with a complaint of a bulging fontanelle, lethargy, and emesis. The family also reported that her belly seems bigger. Next slide, please. We obtained a non-infused head CT, a shunt series, and an abdominal ultrasound. And it was found that on her head CT she had some ventriculomegaly. The shunt series revealed that the shunt was intact. There was no kinking or disconnections noted. And upon further review, an abdominal ultrasound showed she had a large loculated pseudocyst. it was indicated that a shunt tap was needed at that time. Next slide. So our shunt tap revealed CSF. We sent for cell count, glucose, protein, gram stain, and culture. And the CSF was found to have gram-negative bacilli or Pseudomonas in her CSF. So the patient was emergently taken to the operating room for removal of her VP shunt and placement of an external ventricular drain. Next slide. The patient was then admitted to the pediatric intensive care unit, and the nurse received the patient from the OR and assesses the patient and the EVD. She notes that the EVD is already connected to the Becker bag, which is the system we use at our facility. She reviews the EVD orders and hooks up the EVD to the monitor, levels it to the patient, and sets the pressure. Next slide. So in review of the guidelines, the standard location to measure ICP is at the level of the foramen of Monroe. The landmark to approximate the foramen of Monroe can vary from institution to institution, but at our particular facility, we use the tragus. And as Tess had mentioned earlier, it is recommended that you use one landmark throughout your institution so that there is consistency from every nurse to every shift. And some institutions have laser levels or carpenter or string levels that can help with assistance with leveling your drains. Next slide. So the set pressure level is prescribed by a physician or an advanced practice nurse. And for our particular patient, the EVD was zeroed at the tragus and set to a pressure height of 5 centimeters of water. Remembering that when a patient's ICP is higher than the set pressure level, CSF will drain into the barotraum. This patient had an ICP range from 2 to 7. Next slide, please. So as our patient is being closely monitored in the PEDS ICU, her neurological status and EVD are assessed every 2 hours at a minimum. The guideline recommendation is every 4 hours for a whole system review, but children are at a greater risk for over or under drainage due to their developmental capabilities, and this will be discussed shortly. Next slide, please. So as stated in the guidelines, during this assessment that is occurring every 2 hours, the nurse should be assessing the patient for signs of increasing ICPs, such as their fontanelle, is it bulging or sunken, is the patient vomiting, are they lethargic, are they increase in agitation. Next slide, please. So here we have a picture of a non-infused head CT. And this would be an example of a bulging fontanelle. And as you see, the bright white area around the rim would be bone. The gray area is brain, and the black area would be a CSF space. So for this particular patient, as you can see, she has a very large open fontanelle, and there's a small amount of brain with CSF space protruding outside of the rim of the skull. Next slide, please. So in addition to our patient assessment, the system also needs to be assessed every 2 hours. It's important to verify the patient position, the EVD position, the patient's ICP, the color, amount, and clarity of the CSF. And any changes would need to be made sure that the advanced practice nurse or physician is notified of any changes. You need to make sure that the EVD is open or closed based upon your EVD orders. And then, of course, making sure that the CSF is flowing through the tubing and maintaining patency. Next slide. So in the guidelines, we've included some troubleshooting. At times, the systems can malfunction. And so is the EVD draining too much or too little? Are you maybe not getting an adequate ICP waveform, or is it what we would say dampened and not getting a waveform at all? Sometimes air bubbles or debris in the EVD tubing can cause these dampened waveforms or inaccurate readings. So it's important to look for any type of kinks or air bubbles or any debris in the tubing, and the appropriate people notified if the nurse should find those things in the tubing. It's also important to make sure all the system stopcocks are in the appropriate direction. Next slide, please. So young children do not have the developmental capacity to understand that they can't sit up or roll around freely in their crib. And since EVDs are gravity-dependent systems, children can easily overdrain with a simple position change. Those infants that are in cribs with drains can underdrain if their tubing is allowed to drape over the crib rail. So it's important to have astute nursing skills to make sure that they are draining an appropriate amount. Next slide, please. Literature shows that the normal CSF production in children is approximately 0.33 mLs per kilo per hour. So for our particular 10-kilo patient, she would produce approximately 3 mLs an hour or 72 a day. So it's important to closely monitor their output. If the patient is overdraining, the nurse may need to verify the position of the patient and the pressure level. And if they're draining too much or too little, that would be a red flag to make sure we're talking with the physician or APN to make sure that our pressure level is at an adequate position. Next slide, please. And here we have another example of a non-infused head CT. And this particular one, we see that the anterior fontanelle is open and sunken. This can be a variant of normal, or it could be indicative of overdrainage. Next slide, please. Overdrainage in children can lead to complications, of which would include hypovolemia, a subdural hematoma, dehydration, or hyponatremia. In our institution, we replace the CSF output 1 ml per ml for children under the age of 1. Next slide, please. So our recommendations from the guideline are to maintain the EVD at the prescribed 0 reference and pressure levels, to clamp the EVD when the patient response is expected to raise an ICP, such as if the patient's getting suctioned or if it's time for them to be feeding, if they're having any type of invasive procedure such as a peripheral IV insertion or a central line placement, any type of movement or transport of the patient outside of the room or within the room would require clamping the EVD to prevent over or under drainage. It's important to provide education to the families about the height of the patient and the EVD as well. They are at the bedside typically more frequently than the nurse, and they can help with keeping the patient calm and in the appropriate position that is optimal for just the right amount of drainage. Next slide. So the guideline states that daily CSF surveillance labs may expose the EVD to contamination and should be avoided. Our patient had gram-negative bacilli in her CSF, and so we chose to send CSF daily because we needed to monitor the clearance of the bacteria out of her CSF. So what are we looking for when we are looking at CSF labs? Well, we want to know the ratio of the white blood cells to the red blood cells, and the lower those numbers are, the lower amount of bacteria are left in the CSF. We also look at the ratio of glucose to protein. When you have a really high protein and a really low glucose, the likelihood of bacterial meningitis is still present. And then, of course, the gram stain and culture are sent to look for bacteria and hence the susceptibilities for an appropriate antibiotic selection. And in our institution, we use the infectious disease department and team to help us facilitate with the appropriate selection. Next slide, please. So depending on, some antibiotics are only allowed approval by our infectious disease team, and that's probably based off of the increase of MRSA in our geographic location. And so they were given based on the culture results. Intraventricular administration of antibiotics has been advocated, but there is currently no antibiotic that's been approved for this route of administration by the FDA. And in addition to that, there are no dosing recommendations for the medications for intraventricular administration. Next slide. So our patient was given IV antibiotics for 10 days, and we count day 1 as starting from the first day of the first negative CSF culture. So after completion of the antibiotics, the patient was taken to the OR for removal of her EVD and placement of her VP shunt. Next slide. So it is important to, as I had stated, to educate the families on what to expect when their child has an infected shunt and needs an EVD. The family should expect to be in the hospital for an extended stay of at least a week, if not more. And so families need to adjust their schedules and their work schedules and their family life to account for this long hospital stay. Fortunately, at our institution, we have a Ronald McDonald House for our families so that they're allowed to stay close to their family while they're in the hospital. We also get social work involved so that they can help be a support to the family, as well as assisting with any food and housing that may need to occur while they are here for this long hospitalization. And that concludes the pediatric case study, and I will send it back to Pat.
Thanks, Paula. So now we're going to take some questions that are different. If you listen to the original webcast, these are questions that we received from the participants after the webcast was over, and we thought this would be a good opportunity to let everyone know what these questions and the responses were as well. So I'm going to be calling on both Tess and Paula to help with the answers. So question number 1, Erin wrote in, how do you manage the dressing for your EVDs, or more specifically, do you keep the site undressed and clean daily? If so, how often and what do you clean with? Tess, would you like to start?
Sure, there isn't any data. That's a great question, and there just isn't any data for EVDs. So oftentimes we fall back on the CDC guidelines for central dressings who are have plenty of data. So we do use an occlusive dressing, but we do not clean the site daily.
Okay. So Paula? Oh, go ahead.
The only thing I would like to add is that we do the same transparent dressing that's occlusive. And I know with the new product, ChloraPrep, a lot of people are now using the ChloraPrep swabs or a version of those swabs to clean the central lines. Unfortunately, the pamphlet that comes with that says that it is neurotoxic.
Right.
And so a lot of people want to know if they can use that on the site. And I just want everyone to know that currently it is saying it is neurotoxic. So we do not recommend that product is used anywhere near our EVDs.
Yeah, thanks, Paula. We actually don't use that either. For the same
we
reason.
don't either. I work at another facility. I work at Harborview, and we clean either with normal saline, sterile normal saline, or sometimes betadine, depending on physician preference. But we definitely don't use the ChloraPrep at all. So, great. So question number 2. So this was from Diane. Are there standards or regulations regarding placement of EVDs at the bedside while the patient is in the ICU instead of the OR? Are there any benchmark data to base infection rates when the EVD is placed at the bedside? Tess?
The ICU versus OR complication rates are really quite similar, and there's a couple references in the guidelines. I want to say both 2009, but it might be 2008, 2009 literature. With the exception of infection rates, there is literature to say that the OR versus the ICU is different. In other words, the infection rate in the OR is less, and that's from 2005 data, so that's a little bit older data. Otherwise, there isn't a lot of literature out there that tells us about that. And just speaking from personal experiences in the facilities I've worked at and the one I work at currently, almost all the EVDs are placed at the bedside in the intensive care unit.
Paula, what do you want to say about that?
I agree with all of Tessa's comments. The only thing I do want to add is whatever the infection rate is for an institution's particular, whatever the percentage rate is for their institution. I know in the guidelines it states that it's recommended that practices should be reviewed and changed if your infection rate is greater than 10%.
Agreed.
Okay. All right. Question number 3 from Helen. Do most use continuous monitoring or continuous drainage? What is the disadvantage of continuous drainage, and how do you calculate centimeters of water when you read it on the monitor, which is in millimeters of mercury? Tess?
As far as using continuous monitoring or continuous drainage, it depends on the diagnosis of the patient. Mm-hmm. So oftentimes with our TBI patients, we have continuous monitoring, unless this really becomes labor-intensive for the nursing staff with intractable ICPs. Then we have to think about either, if we're just going to use an EVD monitor to manage ICPs, then we might want to check it more often, for example, every 15 minutes mm-hmm. instead of on an hourly basis. Or oftentimes with trauma patients, we might use 2 devices and have something that continuously monitors, for example, a fiber optic catheter and the EVD open to continuous drainage. In aneurysmal subarachnoid hemorrhage, there aren't too many people that don't agree that continuous drainage is the way to go, and there isn't a disadvantage to that unless their patient has a large intracerebral hemorrhage. For the most part, these patients usually don't have ICP problems, and what is toxic in these patients is the blood, so we have to get that out of there. As far as the calculating centimeters of water and millimeters of mercury, those are really 2 separate concepts. So one of them is when the pressure in the head gets to a certain level, which is centimeters of water, then the CSF starts to drain. The transducer is going to appreciate the ICP, and that will be in millimeters of mercury.
Great, thanks. Paula?
So I don't have any additional information necessarily, but in children, it does obviously depend on the pathology of why you have your drain in place. But more times than not, we do the continuous drainage for the EVDs.
Okay. Next slide, please. Okay, question number 4 from Tracy. A statement was made that there were no antibiotics approved by the FDA for intraventricular use. I was wondering if this applies to both the adult and the pediatric population. So, Tess, tell us about the adult population first.
So the guidelines talk about it doesn't stipulate which patient population. So it's actually the adult patient population. And I do want to say it doesn't mean it's not used. It doesn't mean that intraventricular intrathecal medication isn't used, but there really isn't a lot of great supporting data. For the physicians who believe in it, though, they really believe in it, and there are a couple of papers that advocate it. But for the most part, there isn't a lot of great data out there.
And for pediatrics, typically speaking, if the FDA doesn't approve it for adults, then it's not going to be approved for children.
Right.
Because as you know, most clinical trials are done on adults first, and then, if it's safe, then we do apply that to the pediatric population. But because it is a little controversial, we typically do not do it in our children.
All right. Okay, thanks. So this was actually written in by 2 different people, probably in 2 different locations. This is from Karen and Kim. Do you have any information regarding the frequency for changing transducers? The CDC says every 96 hours. So, Tess, what do you have to say about that?
There aren't CDC guidelines actually for EVDs. There are CDC guidelines for changing transducers for A lines and central lines, right? And that is every 96 hours. But that also includes the line. So the entire line is changed every 96 hours. We do change transducers when there's blood or air across the transducer, and as a troubleshooting for when we have dampened waveforms. Of course, it needs to be changed in that situation. But as far as frequently changing things and an EVD and opening that system is just really not indicated when you're talking about CSF.
Right.
Paula,
do you have anything to add?
I'd agree for the pediatric. Typically, it's changed when we have an issue.
Right. Okay.
Yeah, exactly. Okay, the last question is from Dorina, and she wants to know, can you clarify the proper procedure for zeroing the transducer for ICP monitoring? So, Tess, we'll start with you.
Sure. And this came up because of it came up actually in writing the guidelines because there's facilities who don't perform the traditional opening the system to atmosphere. And our conclusion was, our consensus in our group was that we will perform traditional zeroing. So it would be, we would open the stopcock that's used to zero the system off to the patient and open to air. In other words, open to the transducer and then zero it to the monitor and then replace the cap.
Okay. Paula?
And I agree with that zeroing technique as well.
Right. Okay. So next slide, please. First of all, I want to thank the authors, and particularly our speakers today, for the great amount of work and the products that they have delivered to AANN members, as well as anyone who goes onto the AANN website. You can download these guidelines. You don't even have to be a member. And, you know, our biggest desire is for people to go out there and do the right things for the patients. So thank you so much, Tess and Paula. And I just want to add that due to the large volume of questions, the speakers were not able to address all questions that were asked at the time of the original webcast. And then in conclusion, I would like to say we hope you have found this webcast clinically helpful, and we look forward to your participation in future webcasts. Thanks so much.